All righty.
There we go.
Okay, thank you. Yeah, this is Dong-Jing Fu from Janssen, and so I'm going to present clinical data, follow the two wonderful preclinical presentations before me. So this is my disclosure. So I'm the clinical leader for Esketamine program, and I'm a full-time employee for Janssen. So the esketamine, intranasal esketamine has been authorized in two indications. The first indication is for TRD, and the second indication is for the rapid reduction of depressive symptoms in patients with MDD who have acute suicidal ideation or behavior. In other words, who are in a psychiatric emergency. So the study update I'm going to present today is SUSTAIN 3, which is being conducted to evaluate long-term safety and efficacy data in esketamine treatment with patients with TRD. And this is an open-label extension study that provides patients who joined our pivotal phase 3 TRD study to receive intranasal esketamine treatment until the product is approved in the respective countries and accessible through the local healthcare system, or until the end of this year, the study will complete. So patients from one of the 6 parent studies had to join this study. The first patient was entered in June 2016, and the last patient entered the study in February 2019. And the data I'll present today is from our December 2020 data cut, which has 4.5 years exposure from the study initiation. My colleague Carla Canuso presented at this conference last year an earlier interim analysis, which only has safety data at the time. So the data cut I have today has 6 more months of data and efficacy data as well. So as I mentioned, patients are entering from the 6 parent studies. They could enter into the 4 weeks induction phase or directly to the optimization or maintenance phase of the study. So it depends on their status as a parent's study. If they were non-responders from the parent studies or relapsed during the SUSTAIN 1 study or had a gap on intranasal esketamine treatment in the parent study, they would enter the induction phase. And responders from the parent study would enter to the optimization and maintenance phase. So in the induction phase, patients self-administered esketamine as a flexible dose twice weekly for 4 weeks. In the optimization maintenance phase, patients received esketamine as a dosing interval that was individualized to the severity of their depression. Dosage was 56 milligram or 84 milligram for those who are older than 65 years old. Patients can have the 28 milligram. Safety assessments include adverse events and adverse events of clinical interest, and efficacy assessment includes a clinician-reported outcomes such as MADRS and CGI-S, and patient-reported outcomes on their depressive symptoms, functioning, quality of life, and their treatment satisfaction. And all patients are also treated with their background antidepressant. So this is a global study that enrolled 1,148 patients from 28 countries in Europe, North America, South America, and Asia. The ages patients were from 18 to 83 years old, with over 10% was 65 years or older. And 2/3 were women, and about 1/4 of them had a history of hypertension. So 458 patients entered the induction phase. Of them, over 90% continued into the optimization and maintenance phase. So we have 8% discontinued during the induction phase. And the top reasons are on the left top box were lack of efficacy in 2%, and non-responders in 2%, and adverse events in 1.5%. And 690 patients directly entered into optimization and maintenance phase after their parent studies. So we have a total of 1,110 patients enrolled in the optimization maintenance phase of study. Some of them were from induction phase. So of this over 1,000 patients, 30.8% discontinued by the time of this interim data cut, and 5.3% due to adverse events, 4.4% due to lack of efficacy, and 4% withdraw consent. And the majority, the other 15%, were due to other reasons. For example, their symptoms improved, they didn't want to continue the treatment, their scheduling, logistic conflicts for coming to clinic frequently, they moved to different places, starting new job, and patient choice, etc. So because the study was designed to provide long-term access, and when the product is available in respective country, patient would be exited so they can be treated as part of the standard of care with esketamine. So since the December 1st, 2020 data cuts, and patients from US, Sweden, France, and Belgium had exited study because products are available locally. So right now we have 471 patients who are still ongoing in the study and until the end of this year. So at the interim data cut, the median exposure to esketamine in the SUSTAIN-3 study was 37.7 months, and the mean exposure was 31.5 months. This resulted in a total exposure of 2,779 cumulative patient years for esketamine treatment. So this bar chart showed the duration of cumulative intranasal esketamine exposure. This includes their exposure in the parent study. So you can see over 1,000 patients were on esketamine treatment for at least 6 months. 866 patients were on for 2 years or longer. We have over 700 patients were on treatment 3 years or longer. And on the right part, 173 patients were on 4 years or longer. So since we still have 471 patients ongoing in the study, the number of patients with longer duration is expected to increase when we have the study end this year. So now in the study, patients were treated with flexible dose of intranasal esketamine, which is determined by the investigator based on efficacy and tolerability. Investigators could also adjust dosing frequencies when they plan for the next dosing session based on the CGI scores. And if it's moderately ill or more severe, usually they increase dosing frequency. The flexibility of dosing was designed to mimic clinical practice. So this table shows the final dose in each treatment phase by the interim data cut. So you can see in the induction phase, both induction phase and optimization maintenance phase, 84 milligram, majority of patients has 84 milligrams as their final dose. 21 to 31% of patients in each phase received 56 milligram as their final dose, and 1 to 2% received 28 milligram as final dose. Again, which is only available for patients 65 years or older. With respect to the dosing frequency determined by investigators, most of the participants, investigator planned to dose them either weekly or every other week. During entire study, with a small percentage of participants were dosed every 4 weeks. So this dosing frequency pattern were pretty consistent for the duration of optimization and maintenance phase. So for the next several slides, I will present the efficacy data. So this figure shows the clinician-rated depression scale MADRS change over time. So the MADRS mean scores are reduced from 28 at the beginning of induction phase to 16 at the end of induction phase, with a mean change of 12.8 in MADRS. And this reduction persisted during the optimization and maintenance phase with a mean change about 1 point. So you can see the figure flat over the 4 years of treatment. And at the end point, 35.6% of patients achieved remission, which is defined by a MADRS score 12 or under at the induction phase, and 46% patients achieved remission at the end of optimization maintenance phase at this data cut. Similar efficacy results were also seen on patient-reported outcomes. So here is the patient health questionnaire, PHQ-9, a 9-item patient-reported outcome measure assessing depression symptoms in the past 2 weeks. So the score range is from 0 to 27, with higher scores indicating greater severity of depressive symptoms. So the mean PHQ-9 total score was 15.4 at baseline of induction phase, which indicated moderately severe, and PHQ-9 total score decreased, which means improved with esketamine treatment with an induction phase endpoint mean score of 9.6, indicating a mild symptoms reported by patients. The mean change from baseline induction phase to the endpoint is 5 points in the total score. The PHQ-9 score appeared to be maintained during the optimization maintenance phase of treatment, as the score are pretty flat. We also have patient assessing using the European Quality of Life EQ 5D5L, which is a standardized instrument for use as a measure of health outcome by a patient. So the EQ 5D5L descriptive system has 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. Patients answer the questions based on their current health as of today. So each of the 5 domains is divided into five levels of perceived problems. Level 1 is no problem. Level 2 is slightly problem, all the way to level 5 is extreme problems. So this slide, the y-axis shows the proportion of patients who reported problem in each of the 5 domains at the baseline. Green bar is the baseline, and red bar is endpoint. The left bar chart is the induction phase, and right bar chart is optimization maintenance phase. At the end of induction phase, fewer patients reported problem on self-care, usual activities, pain, discomfort, and anxiety, depression. For example, if you look at the bar of usual activities at beginning of induction phase, 86.6% reported they had problems doing their usual activities like work, study, housework, family activity, etc. at the baseline of induction phase. And At the end point of induction phase, 69.2% of patients reported has problem doing usual activities. So it's shown in the right side of this slide, the levels of quality of life maintained for the 5-dimension stable during the at the end of a maintenance phase. Okay, so another patient-reported outcome measure was Sheehan Disability Scale, the SDS. The first 3 items of Sheehan Disability Scale assess the disruption of work, school, their social life, and family life, home responsibility, with a recall period of past 7 days. Patient use a 0 to 10 rating scale. So in this slide, we reported the remission defined by the SDS total score, which if it's 6 or less, or every single item score is 2 or less, which means mildly problematic or functioning impact. So this is a bar chart shows during the open label maintenance phase, about a third of patients were in remission based on their self-reported SDS scores. So in the remainder of my talk, I will review safety results. So this table shows the common adverse events with a rate of 10% or higher occurred in the SUSTAIN study by different treatment phase. So the top part is induction phase. The bottom part is optimization and maintenance phase. So consistent with the safety profile of esketamine, many of the adverse events, such as headache, dizziness, nausea, dissociation, somnolence, and dysgeusia or bad taste, were transient, and most 96.7% of this occurred on dosing days and resolved the same day during the combined induction and optimization maintenance phases. Because of long duration of the study, over 4.5 years for the interim data cut, we also observed commonly occurred medical events in the population, such as the nasopharyngitis, flu, upper respiratory tract infection, and urine tract infection. So this slide shows the patient who discontinued the study treatment due to adverse events. So the list here shows events that occurred at least 2 subjects, and there were discontinuation due to blood pressure elevation, dissociation, worsening of depression, etc. And next couple slides, I will show data of clinical interest. Sedation is one of them. So overall, we observed 7.8 of patients reported sedation as adverse events. And 99.4% of the sedation events occurred on their dosing day and resolved the same day. There was no serious adverse events of sedation, or there's no AE of sedation that led to discontinuation of study treatment. We did not see any respiratory depression observed. Sedation was also assessed by the Modified Observer's Assessment of Alertness Sedation, or we call it MOAS, for the first several years of the study. And the MOAS score decreased usually within 15 minutes of dosing and plateaued at 30 to 40 minutes and then returned to near pre-dose level by 1 hour. Dissociation is another clinical interest event, which is reported by 24.4% of patients. and 3.2% of patients had a dissociation event lasted longer than 2 hours. So that's what I showed in this figure on the left. Rates of dissociation that was longer than 2 hours and over time of the study duration. So initially there's the weekly rates in of 1 to 2% in the induction phase, and then followed by about 1% monthly rates, and the later part we plotted a quarterly rates in optimization maintenance phase. So they're under 1% rates as well. So 99.8% of dissociation occurred and resolved on the day of dosing. There's no serious events reported related to dissociation. We have fewer subjects required concomitant treatment, and 0.4% discontinued due to dissociation. And this slide showed blood pressure related events. Overall, 79 of patients experienced an adverse events of blood pressure elevation during the study. The figure showed the AE rates over time, initially weekly rates plotted, followed by monthly rates, and then quarterly rates. So the rate of blood pressure AE is pretty stable throughout the entire study. And most 96% of blood pressure elevation occurred and resolved on the day of dosing. 6.3% of patients had markedly elevated blood pressure, which is defined in our protocol as systolic equal or greater than 180 millimeter mercury, or diastolic equal or greater than 110 at any time during the study. All these occurrences were transient and resolved the same day. So we have 0.6% patients discontinued study due to elevation of blood pressure. There are cases reported in the literature of bladder toxicity, including interstitial cystitis after prolonged recreational use of high-dose esketamine ketamine, not esketamine, for the ketamine abusers reported in literature. There has been no cases of interstitial cystitis reported in SUSTAIN-3 study, which has exposure up to 4.5 years long-term treatment. There were cystitis-related events such as dysuria, micturition, urgency, etc. And those events were mostly of mild in severity, transient and self-limiting, and considered potentially suggestive of infectious etiology. We did observe UTI in about 13.43% of patients, and we did a careful look to see what is the background rate of urinary tract infection in patients with TRD. So the database analysis or claim database analysis showed 14.4% with TRD, had UTI in a year, yearly rate. So our reporting observed rate is pretty similar to what is reported in the background of TRD patients. This final safety slides showed the serious adverse events, which is reported for 14.9% of patients. And for the long duration of study is expected. So the serious adverse events, just a reminder, are the events that require hospitalization or resulting in death, life-threatening, or considered medically important by investigators. So the only SAE reported in greater than 1% of patients were depression or worsening of depression that required hospitalization. Investigators consider the majority of SAEs to be doubtfully or not related to esketamine treatment. There were 5 deaths occurred by this interim analysis, including 1 complete suicide during induction phase, 4 days after the last dose, and one patient died of multiple injuries due to hit by a car while riding a bike 6 days after last dose, and 1 patient died of MI 6 days after the last dose, and 2 patients died due to COVID infection. None of the deaths were considered by the investigators as related to esketamine. So this concludes the data presentation. So in summary, the SUSTAIN-3 study is an open label extension study to evaluate efficacy and safety after long-term intranasal esketamine treatment. And esketamine treatment is on top of their background oral antidepressants. So this represents a largest cohort with the longest duration of intranasal esketamine treatment. During induction phase of twice weekly esketamine treatment, patients showed a decrease in their depressive symptoms, both measured by the clinician-rated MADRS scores, and the improvement was also shown or seen by the patient-reported outcomes on depression and their functioning. And the improvement appeared to be maintained during the optimization and maintenance phase. And most clinical relevant safety findings were mild or moderate in intensity and were transient. There were no new safety concerns identified with continued intermittent esketamine dosing for up to 4.5 years, which is comparable with the existing well-characterized safety profile of esketamine that has been observed shorter-term studies. Specifically, long-term exposure to esketamine yielded no additional concerns or trends related to cognition, suicidality, drug abuse, dependence or withdrawal, or interstitial cystitis, renal adverse events, or hepatic adverse events. I didn't report all of the data because my colleague Carla Canuso presented key data last year during this conference. So the study will come to conclusion by the end of this year, and we will be releasing our final study results next year. So I would like to thank our investigators, our participants of the study. It has been a long treatment, long journey for the study, and many efforts has put in to the study and provide access to the patient. And I'd like to thank my colleagues. I know some of our investigators are also in the audience for this conference, and thank you for your attention.
A really fascinating talk. We've got time maybe for just 1 or 2 quick questions. Anyone?
Hi, Esther Hagai from Flexio. I just wanted to understand.
Can you not,
please? Oh, sorry. Yeah, I just wanted you to confirm that you enrolled non-responder to the induction and responder to the maintenance, regardless of their initial allocation to placebo or esketamine in the parent trial.
Right. So if they are non-responders, they usually enter to induction phase, right? So if they're responders, they enter to optimization and maintenance phase. And for those who entered in induction phase, at the end of induction phase, if investigator evaluate benefit risk, and there is a benefit for patient to continue the study, they would be transitioned to optimization and maintenance phase.
Yes, but the response was You entered any patient regardless of whether it was initially randomized to placebo or esketamine?
Correct.
Okay,
Correct.
thank you.
Yeah, yeah. There are placebo patients enter to induction phase, and placebo responders could enter optimization and maintenance phase. Yes.
Yeah.
Hi, Toby Martin, Mindful Health Solutions in San Francisco. So we're examining a case series from our clinic right now, about 120 of our patients who have been on Spravato for 6 months. So more of a real world situation. And what we're seeing is looking interesting and a little different from the data here. I'm wanting to comment on it. The main thing that we're finding interesting is that the nadir of the PHQ-9 in our population seems to be occurring around week 16. So a solid 4 months of treatment, we're continuing to see a slower response trajectory than what we've seen in Transformer and Sustain. And I saw that the data here, it looked maybe closer to week 4 to 8 in the Sustain 3. I'm wondering if you have any thoughts on different response trajectories, and is that something you might go back and look at, looking at mediators and moderators?
Yeah, yeah. So that's a good point. So for the Sustain 3 study, of course, patients were in the parent study before. So, and here the trajectory, it included their prior treatment and then continue the treatment through the study. So we also look at the Sustain 2, which is open label 1 year treatment. It's the interesting point. We can take a further look on the trajectory of responders, both in their symptomatology and their functioning. Usually they are correlated, and not everybody respond, but we see rapid response, and then they continue. Some patients continue slowly improving through the several weeks or a couple months, etc. Yeah, different trajectory of different patients we do see.
Rupert's got one quick
What was
question.
your treatment of the dropouts?
Can you repeat the dropout question? I didn't quite get it.
What was your treatment of the dropout data?
Yeah, the treatment of dropout data. So from the study perspective, when they discontinued study, we do not collect additional information afterwards. So we don't have systematically data collected after dropouts.
But their data were included, the data up until the point of were included.
So now some of our parent study, short-term study, we do have the 4 weeks treatment and followed by 2 weeks. Some of them are 6 months of collecting data when they are on regular standards of care treatment, right? Not for Sustain 3. So for those data after treatment and then followed by a standard of care, we are observing as part of the safety assessment to see if there's any, for example, withdrawal symptoms and rapid deterioration, but we did not observe those safety events.
Okay, yeah, we're a bit over time, so there's some questions online, I think, perhaps. No, but if you're able to answer them or ask questions of Dong-Jing in the chat on the speaker forum.
Okay.
Yeah, so thanks again for your really
Thank you.
interesting talk.